Language barriers. Anybody in here speak a different language? Oh, what do you speak?
Swahili.
Hmong. Hmong.
Hmong.
Okay. Cool. I speak Albanian.
That's its own language.
Huh?
So that is its own language.
Hey, I grew up there. Look, I used to have bad draw when I was in the Army. They used to give me, heck, it's not near as bad as it was. So, sometimes if you run into somebody, so you speak Swahili? Alright, so, okay, so we're together, you got Swahili, whoever speaks, what country's that? East Africa, okay, cool. So y'all got that, right? You got the Arabic. So, what about Spanish? You speak Spanish? Little? Anybody speak Hangul? I know how to cuss in Hangul, so I probably can't use that. So I learned that in Korea. That's the Korean language. Okay, so let's say we go into area and it's Koreans and they're injured and they don't speak English. So how are you going to treat them?
A family member that speaks both languages.
What if they don't?
Our friend.
Find somebody.
A bystander.
Nobody. Cell phone service don't work. Look, mine's like 10% left, so I can't.
You get a radio, maybe call dispatch for a translator.
No, if possible. You know, try to keep it simple. Use hand gestures if you have to. If you cannot communicate with them, well then you'll do a full physical exam on them. Treat them for the work, treat them for what you see. It's kind of hard. Consent's an issue there, isn't it? Like, are they giving you consent or what? But I would err on the side of patient care. If in doubt, what do? Call medical control, right? So if you have a patient that you cannot communicate with, you can't get in touch with them, call medical control, ask them what to do. I'm going to tell you, you'll probably get in more trouble by leaving them if they were if they wanted your help and you just left them. And how would you be able to prove that they refused your care? Because you can't understand them. So I'd almost think in a thing of law, you would have an argument, but call medical control, call supervisor, try to get an interpreter. But if you can't, err on the side of patient care. Don't just leave them. So let's say we did a thing in Newton County, okay? We came up with this great idea. When I was in college, came up with this great idea. Let's come up with a book that has medical phrases, you know, like questions, general questions I would ask you if you spoke Spanish that, you know, that I would need to know. And have like the questions and have it in Spanish, you know, so I could see it in English and Spanish. So I'd just point to it. You think that worked?
No.
Why?
Couldn't read.
Because they couldn't read. They were illiterate. So it didn't, I mean, it did sometimes it didn't. So if you try that, it may or may not work. But you know what? Is it worth a try? It could be. And be aware of the language diversity in your community. In the community you live in, if it's primarily a lot of Spanish speakers, you might need to take some Spanish classes. If it's Swahili, take Swahili. Hearing problems. Ask questions slowly and clearly. Matter of fact, I've had students that have hearing problems. I've had some that had vision problems. That's some that hardly could speak English. They spoke French, really good French.
Your last class, she was partially deaf, wasn't she?
Yeah. And she'd have to see my lips.
Mm-hmm.
So use a stethoscope to function as a hearing aid if you have to, and learn simple sign languages during your career. And if you have to, write stuff on paper. Visual impairments, identify yourself verbally when you enter the scene. Return any items that have been moved to their previous position, because they will memorize their environment. And if you move the foot stand into their normal route of traffic, they could trip on it. Okay? And while you're transporting someone who's visually impaired, try to stay within physical contact with them, usually on their shoulder. touch their shoulder or something so that they know you're there. Okay, so going into the secondary assessment, I know this is a lot, y'all. I know y'all are dying, but we're almost done. And y'all will be all lectured up. The secondary assessment, this is performed on the scene, in the back of the ambulance en route to the hospital, or not at all. So depending on the situation of the patient, you may not do it, or you may do it on the scene, or you may do it en route. Typically, we will do it on scene because it's pretty quickly. And the purpose of this is to perform a systematic physical examination of the patient, and it may be full body scan or an assessment that focuses on just one part of the body.
Sir, can you hear me? Sir?
It's unresponsive.
Yeah,
Perform a rapid physical exam.
well, he's breathing.
Assess the pulse rate,
Yep.
strength, and regularity. Inspect and palpate the scalp.
There's no depression or loose bone. The occipital region's okay.
Inspect and palpate the face,
Sinuses.
Inspect the
are okay.
nose.
I'm just gonna look at his eyes here.
mouth. Inspect the eyes and pupils.
Pupils are equal and reactive.
And ears.
Seeing blood or CSF in the ears.
Inspect and palpate the neck. Look for jugular vein distension and tracheal
Why
deviation.
don't we get a collar on him? John, we're glad you're here. Why don't you go ahead and pass off C-spine?
Inspect and palpate the stability of the chest wall.
Well, there's no open wounds.
Look for bleeding,
Bruising.
bruising, discoloration.
There's no fracture that I can feel. I don't feel any subcutaneous air or emphysema.
Assess the respiration rate, depth, and
Can you
quality.
give me some lung sounds here?
Inspect and palpate all 4 quadrants of the abdomen, looking for bruising and distension.
There's no masses on palpation. All right,
Palpate for instability in the pelvis.
the pelvis seems really stable. I don't think
Assess the
there's any fracture.
genitalia and perineum if appropriate.
There's no fluid or priapism.
Inspect and palpate all 4 extremities,
Blood pressure. I don't feel any fractures. The legs seem straight.
looking for
here.
the quality of circulation as well as motor and sensory function.
Here. Yep, that one's good.
And notice how they're working together as a team, right?
Alright, I don't see any bleeding. There's no major bleeding, right?
No, I don't see any bleeding anywhere.
But you got that.
Alright, he's got a good posterior tibial pulse there.
Blood pressure is 110/70.
Great, great. The right arm looks good. Pulse is still strong. Cap refill's less than 3 seconds.
Left arm's good. No deformities, no bleeding.
Alright, John, I think we're going to do a log roll here and examine his back. We'll go on your count, okay? Maybe
Inspect and palpate the thoracic and lumbar areas of the spine and entire back. Make this a thorough inspection. If the patient is to be placed on a backboard, this will be the last exam of the back you will be able to perform.
Deformities on the spine either.
There's no ecchymosis near the spleen or kidneys. That's good. Looks good. Alright, let's roll him back.
Okay, on 3. 1, 2, 3.
Alright, you guys keep an eye on him. I'm going to go grab a backboard, okay?
Alright.
Ideally, you should have the backboard ready to pull right behind them already. Alright, so let's watch this one as well.
Inspect and palpate the scalp. Inspect and palpate the face. Inspect the nose, mouth, and ears. Inspect the eyes and pupils. Inspect and palpate the neck. Look for jugular vein distension and tracheal deviation. Inspect and palpate the stability of the chest wall. Inspect and palpate all 4 quadrants of the abdomen, looking for bruising and distension. Inspect and palpate all 4 extremities, looking for the quality of circulation as well as motor and sensory function. Palpate for instability in the pelvis. Assess the genitalia and perineum if appropriate.
What was it?
Right ankle.
Right ankle? Okay. With your left one, can you push forward?
Yeah.
Can you pull back?
Yeah.
Okay, can you do it with your right?
Uh-huh.
No? Okay. Alright, he's got a pulse. It's a possible prick. I'm gonna spoon it with a pillow. Alright? Run it back for him and go, alright?
Anything you do to make it better or worse?
You always carry a pillow with them?
Yeah, usually a pillow on your stretcher.
And your sharp pain, dull pain. So we're gonna put you on back right.
Alright, sir.
I'm gonna roll you up, I'm gonna check your back. Keep your legs together for me. As much as possible.
Inspect and palpate the thoracic and lumbar areas of the spine and entire back. Make this a thorough inspection. If the patient is to be placed on a backboard, this will be the last exam of the back you will be able to perform.
Each side, underneath, alright. Check down his back, butt, good. Legs alright?
Okay, so getting vital signs. We want to use the appropriate monitoring devices. Like we can use a pulse oximeter to get a pulse ox reading, which is a pulse ox reading gives us the amount of oxygen molecules that are circulating in the hemoglobin. However, it can be wrong. So we can't go by this 100%. It will also give us a pulse as well. But that does not mean that you cannot check for a pulse by palpating as well. You should do both. Patients with difficulty breathing, we should utilize pulse oximetry. But we're going to administer oxygen based on the patient's needs, not based primarily on pulse oximetry, okay? Does that get you in trouble? Non-invasive blood pressure measurement. This is the automatic, or this can be the automatic blood pressure machine, or what we normally use when we learn how to check a blood pressure using a blood pressure cuff. Typically on the ambulance, we're going to be using the regular blood pressure cuffs, but they are starting to come out more because a lot of the LifePak or the monitors now have automatic blood pressure capabilities on it.